Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, the astute medical student is probably looking at this granuloma and has already realized that it is a naked granuloma, which makes them think of sarcoidosis, right? We're going to be talking about this and much more on this presentation of Restrictive Lung Diseases Pathology. This is covered in your book, Medical School Pathology and Step 1 Review. It has everything in it that you need to understand pathology for Step 1 and to do exceptionally well with your coursework. Let's talk about restrictive lung disease. Restrictive lung diseases are characterized by restricted feeling of the lung where the FVC, the forced vital capacity, is more decreased than the forced expiratory volume in the first second, resulting in a FEV1 to FVC ratio greater than 70%. By the way, if it was less than 70%, what would be on the top differential? COPD, perhaps? Right. But in restrictive lung diseases, the FEV1 over the FVC, or that FEV1 to FVC ratio, tends to be greater than 70%. Now, restrictive lung diseases are most commonly caused by interstitial diseases of the lung and chest wall abnormalities, like obesity. And you might be asking yourself, what are interstitial diseases of the lung? But you already know. Just think about it a little bit. I'm going to say something. I'm pretty sure you're aware of what interstitial diseases of the lungs are, okay? You've heard of asbestosis, right? You've heard of silicosis and coal workers' pneumoconiosis, right? How about bronchiolitis obliterans or interstitial pneumonia? See, these are all types of interstitial diseases, and it's in that word interstitial, right? Affecting the interstitium, okay? So keep that in mind as you go through this presentation. And in regards to restrictive lung diseases, we have some histology showing an image from a patient with severe emphysema. Now you might be wondering, how does emphysema cause a restrictive lung disease? Well, that's because they have that recoil abnormality that causes them to collapse, right? That's how emphysema becomes restrictive. And here we have a specimen from a lung that's clearly showing abnormal nodules within the lung. This is a hypersensitivity pneumonitis with granulomas that are present. And here we have more H&E imaging showing pulmonary alveolar proteinosis, right? And this is a specific restrictive lung disease. But let's talk about something you will definitely be asked about, which is idiopathic pulmonary fibrosis. Now, this condition is characterized by the scarring or the fibrosis of the lung interstitium, as you can see here on this image. Although the main cause is unknown, idiopathic pulmonary fibrosis is likely due to cyclical injury as the injured pneumocytes induce the fibrosis. Now, some causes or potential causes of idiopathic pulmonary fibrosis include cyclical lung injury, chemotherapy such as bleomycin or amiodarone, or radiation therapy, right? So if you have a patient or a clinical vignette that says, X patient's a 49-year-old male with history of lung cancer, status post pneumonectomy, status post radiation therapy, and they're having breathing issues, you can think of a recurrence and you should have idiopathic pulmonary fibrosis on your differential somewhere. Some common clinical features of IPF include cough and progressive dyspnea and cough, right? It can be combined. Imaging will likely show fibrosis on lung CT, and specifically subpleural patches. And those may progress to diffuse fibrosis and eventually form a buzzword that you must know, honeycomb, right? Idiopathic pulmonary fibrosis may have a honeycomb pattern, and that, my friend, is an indicator of end-stage pulmonary fibrosis. The recommended treatment at that point would be a lung transplant. And here we just have a cartoon showing a representative presentation of idiopathic pulmonary fibrosis. Also, a clinical finding in patients with idiopathic pulmonary fibrosis, at least on tests, they tend to have this here. What is this actually? You've seen this before. Digital clubbing, right? Where else would you see digital clubbing? Let's say this was a child, right? Some congenital cardiac defect like truncus arteriosus or something like that. Other causes of this actually include celiac disease, and you might even see it with different lung disorders, right? So keep in mind digital clubbing. And here is some key features at the microscopic level for diagnosing idiopathic pulmonary fibrosis. You'll see this honeycombing, right? It's nice when there's a correlation between radiology and pathology. Note the fibroblastic foci and the dense fibrosis. And here we have representative imaging from a chest X-ray showing small lung fields in a peripheral pattern of reticulonodular opacification in a patient that had IPF. And again, we're talking about idiopathic pulmonary fibrosis or interstitial lung diseases, right? But now let's move on to something that is very high yield because it's so classic. I'm talking about pneumoconiosis. Now, pneumoconiosis is a form of interstitial fibrosis that's caused by occupational exposure like fibrogenic particles like asbestos or beryllium or silica dust, right? For example, take a look at this H&E section. It's a high magnification micrograph from a patient with asbestosis of the lung. Can you point out the ferruginous bodies? They're there. And if you can see them, good job. Make sure you can recognize them because you will see these in the future. Regarding pneumoconiosis, the alveolar macrophages in the lungs actually engulf these particles, which induces the fibrosis. Now, this is super important to note. This is a big deal. It's sarcoidosis. You'll definitely see this. Sarcoidosis is a systemic disease characterized by growing granulomas in various body organs and is more prevalent in African American women, right? So in this imaging, what is this arrow pointing at? Hilar adenopathy, right? Some pronounced lymph nodes on one side, and actually note it's bilateral, right? You see that? Bilateral hilar adenopathy. Classic buzzword for sarcoidosis. Although the etiology of sarcoidosis is unknown, it likely arises from the response of CD4 positive helper T cells to an unknown antigen. And the granulomas of sarcoidosis are quite unique, right? The granulomas mostly affect the hilar lymph nodes and lungs, causing a restrictive lung disease. The histology of sarcoidosis includes naked granulomas and stellate inclusions like asteroid bodies. These are often seen within the giant cells of the granulomas. So on this image here to the right, you should be able to point out at least 10 giant cells, at least. And the astute among you will actually probably see at least 2 asteroid bodies. If you can't see them at this magnification, don't worry. This is difficult for, pathology residents. So don't beat yourself up about it. I'm going to point out a clearly visible asteroid body coming up shortly. But if you can see it on here, great. If not, don't worry too much. I'm going to show you. So other commonly affected tissues in sarcoidosis include the uvea, right, which causes uveitis, or the skin might be involved with these classically seen things, actually, erythema nodosum, right? The salivary glands may be involved, as well as the lacrimal glands. And the clinical features of sarcoidosis include dyspnea and cough. And there are some laboratory findings associated with sarcoidosis, right? Your patients may have elevated serum angiotensin converting enzyme or elevated levels of calcium, right? Hypercalcemia. Steroids are the most preferred treatment, although the condition often resolves on its own. See, I'm not going to let you down. I'm not going to leave you wondering. Here's that asteroid body that I was telling you about, right? This is the asteroid body that is seen in sarcoidosis, okay? Got it? You see it right there in the middle. All right. And to reiterate, with sarcoidosis, classically associated with hilar adenopathy, bilaterally, as you can see here as well. And this is a cartoon highlighting and showcasing various symptoms associated with sarcoidosis. Do note the erythema nodosum for all you future dermatologists out there. Here's your skin lesion. If you see a patient with this, make sure you do a bit of history and physical exam findings to assess for potential findings for sarcoidosis. And this is just another H&E section from a patient with sarcoidosis. Can you see the asteroid body? See, you got it. And hopefully our patients with sarcoidosis won't have their lungs removed and bisected in this manner. Hopefully we can treat them before that. If you are curious, this is what it would look like. Yes, you will probably not see this on your examination, so moving right along. You will probably see this, right? This is more skin findings for you future dermatologists out there associated with sarcoidosis. If you know what this is, figure out a way to let me know. I'm a pathologist. I'm telling you everything about pathology. I don't know all the skin stuff. Defer to derm. But I know what this is, right? You know what this is, right? Obviously. And the future radiologists out there, can you tell me what you're seeing here? Hilar adenopathy, right? If you look closely, you can see it's probably bilateral. You will see this. And this, right? Don't forget. Never forget. Never forget. Never forget. You see the giant cells? This is a bit out of your purview. You don't need to know about TL1A, etc. Just note the giant cells, especially in the top left panel, right? Now let's move on to hypersensitivity pneumonitis. Hypersensitivity pneumonitis is mainly characterized by granulomatous reaction to inhaled organic antigens, like pigeon breeders' lungs, right? Common signs and symptoms of hypersensitivity pneumonitis include fever, cough, and dyspnea. And the symptoms typically occur hours after the exposure. And they fortunately usually resolve after removal of the antigen. Chronic exposure to the predisposing factor causing the hypersensitivity pneumonitis may result in interstitial fibrosis. And with that, you've completed a very important presentation. Give yourself a pat on the back. Make sure you know what bilateral hilar adenopathy refers to. Make sure you can recognize giant cells and asteroid bodies, because I guarantee you will see sarcoidosis. But I have faith in you. You're going to do great. Keep up the good work, and I'll see you later.